Hello and welcome to Asala Richmond Presents second webinar, African Americans, COVID-19 and Health Disparities. My name is Michelle Evans Oliver and I am the president of Asala Richmond organizing branch here in the Richmond, Virginia area. We have been doing this series this is our second week and we're excited to present African Americans, COVID-19 and health disparities. Last week, we had a plethora of information regarding mental health. And with that, we are excited today to hear about health disparities. COVID-19 has ravaged the African American community, and we have been a #1 topic of discussion in media, community, health leaders everywhere. And we here at Asala Richmond felt that we should do something about it in our community. Asala Richmond is comprised of an executive board, and our executive board members are Derek Vance, Vice President, Cassandra Boyd, Secretary, Jay Allen, Historian, Juanita Coleman, she's our chaplain, and Courtney Quarles, who is our moderator for today, and she's our treasurer. Again, I would like to remind, or I would be remiss if I did not acknowledge once again, Caleb, Mr. Master Caleb. He was the one who put together the video in the beginning of this webinar series. Caleb is only 10 years old and in the 4th grade. So we're excited to have him aboard to help us. Our next webinar will be next week, next Sunday at 4 p.m. And we will be talking about African Americans, COVID-19, and human services and community resources. Our speakers for that series will be Tony Blue Washington, Director of the Virginia Department of Social Services Benefits Program, Norm Gold, developer of the Market at 25th and the president of the Virginia Volunteer Organization Active in Disaster. And we have Adrian Cole Johnson, Director of the Family and Community Engagement for Henrico County Public Schools. That should be a very exciting webinar as well, and we hope that you join us. More dates to follow. We have a few people on this call that we would just like to acknowledge. We have the president of Asala National Headquartered in Washington, D.C., Evelyn Brooks Higginbotham. Sylvia Cyrus is the executive director who's on this call as well of Asala National. And Lionel Kimball. He is the vice president of programs for Asala National. We are streaming live on Facebook, and we hope that you will be able to join us if you cannot get in on this call, or if you want to see it again, you can just go to our Facebook page at Asala RVA. We also, if you want to tweet, we have a Twitter account. It's also at Asala RVA, and if you would like to hashtag us, it is hashtag Asala RVA Cares. Well, I am excited about today, and I would like to introduce you to Courtney Quarles. She's our moderator for today. And Courtney is a native of Richmond, Virginia. She's a graduate of North Carolina A&T, and she got the award for the Woodson Award for her research paper on double consciousness. She's a historian with an MA in public history and the owner of the online Invisible Museum. The Invisible Museum was established as a free access online museum dedicated to expanded community accessibility. And without further ado, I would like to introduce you to Courtney Quarles.
Hello, everyone. I'm sorry if I'm a little lagging on the video. Had some technical difficulties earlier, but just want to welcome you to our second webinar talking about African Americans, COVID-19, and health disparities. First, before I introduce our guests, I would like to go over the logistics for today as we changed them. If you were on our previous webinar last Sunday, we will have a 30 to 40-minute discussion with our experts, followed by a closing Q&A for about 10 minutes to answer any questions that we haven't gotten answered. Please feel free to type your questions in the chat room if you're joining from Zoom, or in the comment section if you're joining from Facebook. While you may not see your questions in the chat, I want to assure you that our chat moderators are noting them so that I can ask our experts. We have changed our format so that we can get more of the community's questions answered. Once again, I want to thank you for joining Asala Richmond's COVID-19 Health Disparities webinar. To talk about this topic, we've invited Dr. Hines, Dr. Hunter, and Dr. Johnson. Dr. Hines is the founder of Freeman Moore Medical Consultants, a full-spectrum disability consultation practice. She is a native of Norfolk, Virginia, and is a proud graduate of Booker T. Washington High School. Dr. Hines completed her undergraduate degree in biology chemistry at the University of Virginia. She graduated from Meharry Medical College and subsequently completed her residency at Atlanta Medical Center in internal medicine. Since completing residency, she has worked in emergency medicine in several communities across the Southeast and Southwest. She is also the founder of Freeman Moore Medical Consultants, providing assistance with disability applications and appeals. In her spare time, she is the editor of Globe Meet Trot, a lifestyle blog focusing on travel and health issues. In addition, she enjoys running, baking, and world travel. She resides in Atlanta with her family. Dr. Samuel Hunter is a pathologist and director of laboratories at Richmond Community Hospital in Richmond, Virginia. Over the course of his career, Dr. Hunter has held numerous appointments and memberships, such as American Association of Blood and Banks, Emergency Medical Services Advisory Board Chair, Joint Committee to Study Healthcare for All Virginians, and most recently, Secretary to the Board of Virginia Biotechnology Research Park. He also has several articles published in medical journals pertaining to topics impacting our community, including several on sickle cell anemia. Dr. Hunter attended Florida A&M University in Tallahassee, Florida, and received his medical degree from Meharry Medical College in Nashville, Tennessee. He also received his Master of Science degree from University of Chicago in Chicago, Illinois. Dr. Candace Johnson is a clinical professor at Virginia Commonwealth University School of Nursing within the Department of Family and Community Health Nursing. Her primary area of research is in culturally tailored health behavior, exploring stress management and weight reduction in high-risk African American women. In her most recent preliminary research, looking at yoga practice in community-dwelling Black women, she uncovered significant relationships between a unique determinant of health in Black women and cardiovascular systems associated with metabolic syndrome, a condition that leads to heart disease. Dr. Johnson is currently nursing faculty at VCU School of Nursing, teaching community, public, and population health nursing to senior, pre-licensure, second degree, and RN to BSN students. In addition to nursing education, she provides community-based health education to residents in underserved neighborhoods, including areas served by Richmond City Health District, Richmond Redevelopment Housing Authority, Richmond Health and Wellness Program, and VCU Health Hub at 25th and Churchill, Richmond. Dr. Johnson currently serves as Vice President of Central Virginia Chapter of the National Black Nurses Association. Okay, thank you all for coming. We are so excited to have you here with all of your expertise. I know our participants are eager to have some of their questions answered, but to open it up, I would like to pose a question maybe two of you can answer to open us up. We hear a lot about African American morality during this pandemic. Can anybody give us a short summary of where we stand health-wise prior to COVID-19?
Well, I brought along a model today to kind of help set up a little bit around health disparities and where we were before COVID-19, and a little bit of information regarding where we are now. So if Dr. Willis, if you could pull up that slide for me, I'll quickly go through this slide, but if you would like to talk more about information that's in the slide, we can pull that into our discussion later. But I just wanted to point out to you the fact that when you say health disparities, you're talking about a huge topic that covers a lot of different multifactorial problems. So a lot of people don't like to attack the topic of health disparity so much because there are so many factors involved. But with this diagram, I hope to kind of give you a sense of the fact that health disparities are the tip of the iceberg, but they describe a problem or a scenario that is much deeper, and a problem that is related to a lot of other foundational issues that we have going on. It's not going there for you. All right, there we go. Well, I'll quickly start with health disparities or health inequality. So health inequalities are the differences. So to be clear, health disparities refer to outcomes, whereas health inequities refer to the differences in the resources that we have. So these are usually systematic, they're usually unfair, they cost a lot, and they are definitely preventable. They are rooted in the social determinants of health, and I'll talk a little bit more about those in a few slides. But I wanted to give you a couple of examples of what a health inequity is, especially in the Black community. For example, Black babies face double the risk of dying in their first year of life. That is a health inequity. Black women are four times more likely to die while giving birth than white women in the United States. Only 1 in 5 Black women believe she's personally at risk for heart disease, but heart disease is the #1 killer of all people, but especially African American women. 49% are at risk for heart disease. So life expectancy, HIV/AIDS, you're going to see many types of disparities and inequities prevalent among these groups. So if you can push to the next slide there. I just wanted to give you a setup there. But for structural, if you can go to the next slide there are determinants of health that are connected to structural things that are not that are above the purview of what a normal healthcare consumer can deal with. So those are problems that come from above, like wealth inequality, racism, or problems that you may encounter with discrimination. Environmental racism, which is referring to unsafe neighborhoods and unhealthy living conditions, and provider bias. And when I'm talking about provider bias, I'm talking about ethical dilemmas that you see some providers having to deal with in trying to make choices about resource allocation. So we can talk more about that later. But also social policies and public policies play a huge role. And you see that in the labor market and in housing and in acquiring land. A lot of policies are prevent a proper engagement with the healthcare system. Public policies as well, lots of education issues around social protection. And for example, with COVID-19, a public policy such as the stay-at-home policy or wearing masks in public would kind of be an example of how public policy plays a role in our health. So next slide, please. Cultural determinants of health play a huge role in the decisions and behaviors that we make. This model is kind of set up using the World Health Organization as well as the Department of Health and Human Services models that they have for social determinants of health. But cultural determinants of health, they aren't just the decisions that we make, but those are decisions that we inherit. Beliefs about religion and beliefs around food and what we eat, and even things like working out as being undesirable by people who have a history of free labor. So things like that, issues around like Black hair and the politics of Black hair and how Black hair is expected to be presented, yet when you have to do a lot of vigorous physical activity, it becomes difficult to engage in keeping hairstyles that are consistent with norms that are expected. So when I say this, I'm not speaking to the individuals being at fault. I'm speaking to a system that kind of holds us into these things. Next slide. I'll try to go a little bit more quickly here, is not to spend more time. Family networks, the way we interact with our families, these multi-generational families, or families where you have fathers of multiple female-headed households, or even multiple-headed households. You see situations that kind of set us up for risk, such as what you see in the COVID-19 response, where many people going in and out, and transient members of families and informal family networks kind of setting us up for being at risk for COVID-19. Next slide, please. History, I won't go into this too deeply, but I think we can all connect with an idea that our history informs our behavior, and that being a part of, we touched on this a little bit last week during the mental health health disparities panel that you had there, but there's this trauma that remains from slavery that affects our eating patterns and our sedentary lifestyle, things I mentioned before, like not wanting to work out after having a history of forced free labor. Things like that are definitely playing a role. Next slide, please.
I'm so sorry, Dr. Johnson.
Are we setting up too long here? All right, well, you have the slides there. I can give you access to them, but in a nutshell, I just really wanted to describe how complicated the problem is and how it's leading to scenarios where we can't just talk about health disparities without considering all these conditions here and weighing them in our discussion. So thanks for just letting me, kind of give you a sense of how deep this problem is. And with COVID-19, you are seeing that we are we're being overrepresented in the cases, deaths, not just locally, but also nationally. So thank you.
Yes, thank you. I definitely think that will help all of our participants understand the background to why we're seeing such high numbers within our race, because there are these health disparities. There is this history that is involved. The next question I'd like to pose would be to Dr. Hines. But since you're working very closely with patients, besides wearing a face mask and washing hands, what are some other strategies that we can implement to stop the spread?
Well, the biggest strategy, or the biggest thing that anyone could do, is to continue the shelter in place policies that have been put in place in various states. Right now, in the past week, so I'm here in Georgia, and our state opened up last week, and so we've been seeing what is happening now. And of course, we won't have the data from those openings for another week or so in terms of the number of cases potentially of positive COVID-19 patients. We won't have that data for another week or so. But since we know that coming in close contact with individuals who may be positive and also may be asymptomatic, then staying as far away from people as often as you can is, to me, the biggest strategy that we can utilize to mitigate our risk for contracting COVID-19. So of course, now that everything is open, I recommend that if you don't have to go out, if you don't have to participate in whatever commerce may be open, then I recommend that you continue to stay at home until we start to see a decrease in cases, or until more testing is more widely available. I've been following what's been happening in my home state, and I see that you all are having still like the largest numbers of positive COVID cases. That is still happening. And luckily you all are still under stay at home or shelter in place protocols. So that's the most effective thing, in my opinion.
Thank you for that. Definitely reiterate what we've been told, so people know that it is very important to stay at home. I know that it may not be ideal, but if that is definitely something
it's challenging. I mean, it really is, and we can't we can't underestimate how that is, because if you have children that are at home, but you are an essential worker, then that creates, difficulties surrounding childcare, surrounding how you educate your children. So it isn't, I always like to be careful and respectful when I tell people, that you need to stay at home, because there are so many people for which that's not a workable option. And so, we have to kind of have a dual strategy when we approach this topic, so that we are sensitive to what many, many people are going through, because not everyone can just stay at home.
That's exactly right. So I definitely do think that's something to think about, to be mindful of, that not everybody has the same privilege.
Exactly.
Dr. Hunter, the next question I'd like to pose to you: from a historical perspective, has there been any other disease or social ill that has impacted the African American community the same way that we're seeing COVID-19 impact us? Dr. Hunter, I actually think you're still muted. Give me there.
Okay. First of all, just one correction to what you said about my qualifications. I don't have a master's from the University of Chicago. I only took classes as part of my training program at Meharry.
Okay, I apologize.
Just for the record. Now, tuberculosis has affected our people, and again, it has to do with the crowding and the conditions under which individuals have lived. And this disease is showing that very clearly. Again, you see it in mass in the large urban cities with mass transit, and people are essential. They have to go to work, and they're traveling in close proximity. It's a disease that's respiratory. It's transmitted by the respiratory tract initially, as we believe, and we get caught in the crowds, and the crowds are a problem. And so I agree with what the speakers have said earlier, and I think that we need to be very mindful. And the other thing I would say is that if we're going to improve the health of the patients we care for, we must be involved in civic activities, both our organizations as well as our regular civic organizations, and express our opinions.
Okay, thank you so much. So as you hear here, folks, just to reiterate that staying home is one of the best things that we can do and avoid crowds. The next question that I have will be for Dr. Johnson. A lot of the information coming in speaks of health disparities. What are some of the health conditions specifically that exacerbate the symptoms of COVID-19? I think you're actually muted too. Give me 1 second to get you unmuted.
Okay.
There we go.
Okay. All right. Well, there are so many comorbidities, which are the same as health disparities in this case, that are associated with COVID-19 and African Americans. And it really, there are a lot of the pathophysiology or the way this disease progresses is unknown. So a lot of what we're learning, I sit in on conferences with physicians and medical teams, and they are saying we are building this airplane as we fly it. That's why a lot of them are using that terminology. So medications, protocols are changing, ICU protocols. So we need to know in the community that once you get into the, if you suspect you're having yourself of having COVID, or if you are trying to prevent from getting it, which most of us are, we don't want to overwhelm the healthcare system, and we don't want to possibly be part of that 20% of people who have really bad outcomes. So 80% of people get it, they're asymptomatic or they're mild, they have mild symptoms, but 20% of people are so sick that they may need to go to the hospital. And of those people, the ones with the comorbidities are at the highest risk of doing poorly. And the numbers that we're seeing is around 50% of people who do go into the ICU do not make it out. So a lot of that has to do with the types of disease processes that they already have going on in the body. So I'll just mention a couple of them, the comorbidities that are listed. Hypertension, in a recent study that just came out last week of 5,700 patients in New York City, they saw that the majority of the people there, I think it was about 96% of the people had some issues with hypertension. Type 2 diabetes is also highly connected to this issue. And also obesity, meaning that you have a BMI of greater than 30. That puts you at high risk. Also overweight to obese individuals have a big problem with that. So those are just some of the few of the risk factors. If you have more severe disease like kidney disease or liver issues, then it becomes even more of an issue. So when I say that Black people, because we actually are a group of people who already have a lot of comorbidities, we have to do as Dr. Hines says and stay inside, because it really does come down to protecting ourselves. Because we're so high risk, the likelihood of having a really bad outcome is high in our population.
And if I may piggyback on Dr. Johnson, one of the challenges is that we don't know as of yet which populations will be more adversely affected than others. So we've all seen in the news where you'll have someone who is in their 40s and healthy contracts this disease and dies, whereas someone who is elder and may have a couple of these comorbidities will survive. And we don't know why that is. There is no pattern or rhyme or reason that has been established to help us in the medical community to identify who might have a milder course and who might have a more severe course. So that is all the more reason to, continue to shelter in place, because if you get it, you don't know, and we don't know how severely or not severely you'll be affected. It's a gamble.
And it's a sad course when you go into these environments. We're seeing a lot of nurses complaining of distress over being on the front lines and seeing patients separated from their families because of the high infectiousness of this disease and dying alone, or there not being enough resources. So really, I really want to double down on this idea of us being more careful, because when we do get into these hospital systems, it becomes very difficult to manage things and get our family members involved in the care, which is something that we like to do. But it becomes tougher when, you have to be separated from your family. But when we are getting in there, we're seeing people who have to wear PPE, and it's very impersonal. There's also the telehealth that's happening inside the hospitals, where the doctors are having to call you on the phone to talk to you through the glass. So there's a lot of about COVID-19 in the health response to it, that we still just don't have enough information to kind of just go in there and trust that the medical system is going to take care of us and we're going to get in there and get out of there. A lot of things we just don't know. So it does require us to be more hypervigilant and to take care of ourselves so that we don't even get COVID-19 in the first place. But if we get it, like Dr. Hines said, and you don't know if you're one of those people who will do poorly or not, then it's really a good idea to just avoid it.
Right. So I do have a question that just came in from one of our participants. It is for Dr. Hunter. This came from Maddie McKnight. And I'm going to read what she typed in, so you let me know if maybe if something is incorrect in the way that she wrote it. How has COVID-2 affected the African American community? And she states that this came from the New York Times.
Today's New York Times has some very interesting comments about the virus and its effect on individuals who use public transportation, if I am remembering it correct. And in the previous Sunday edition, likewise. And there is some real questions about the structure of our living conditions and some other issues that have played out. Several nights ago, an interview with the director of policy for the Philadelphia Children's Hospital raised the same question again when asked by an interviewer. What did the close proximities of transportation have to do with the spread of the virus? And I don't think anybody has really handled that with actual proof, but that is raising its head as concern. And the African American community often has employment that requires close proximity with the public. And as a result, that is a higher risk because, again, we're talking about a highly transmissible disease that is respiratory in nature. And so we have to keep our distance from each other. And density of population has some effect.
Thank you, Dr. Hunter, for
I
answering.
hope I've answered that to the extent the individual was looking.
If your question was not answered fully, Madam McKnight, please respond in the chat and we can get some further details for you. I have another question here from Maria Brown Marshall. I will leave this up to one of you all to answer. What additional resources are needed for our community given this given the disparities effect on African Americans?
Well, one of the things that is going to be paramount in our community is mitigating our risk factors. And we know that when we talk about, especially with Dr. Johnson's excellent slide about disparities, that the lack of access to care existed in our community before COVID became a hot topic. So what we know is about 20 to 25% of all Americans don't have a primary care provider. Of that 20 to 25%, about 12% are African American. So when you don't have access to care, even if you feel ill, want to be screened, you don't have anywhere to go. Because most people will think about the emergency room. The emergency rooms are not doing screenings because in many emergency rooms, there isn't enough testing for the people that we actually suspect, let alone the people who would just want to be screened just to know what their status is. Unfortunately, we aren't at that point yet where we can screen everyone and then put forth strategies as to what those individuals should do going forward. So taking care of our risk factors, knowing our risk factors, those are going to be important tools that will help us in terms of mitigating our risk for contracting COVID and just for your health in general. So if you have diabetes, you need to know that you have diabetes and know what to do about it. If you have high blood pressure, if you have asthma, you also have to have access to the medications that will treat these disease states so that you can maintain your optimal health as much as possible.
And what's great about this this COVID-19 pandemic is that we've uncovered these and discovered these wonderful ways to increase access to health now because of the social distancing requirements. Now we have telemedicine and telehealth flying through the roof, and it's a wonderful way to increase our access as a group of people who don't, as Dr. Hines said, 25% of us, only 25% of us have a primary care provider. We can increase that and improve that by finding out how best to access our primary care folks by telehealth. That would be a great way for you to get involved in checking up on your pre-existing conditions and seeing how you can make sure that you are where you need to be with your targets. But telemedicine is really improving now and really giving us better access. So check it out. I don't know if all the policies are going to be the way they are right now, but all of us can access our healthcare providers this way now. So it might be a good time to start now. From my understanding, many are operating at about 75% of their prior capacity. Many of the doctor's offices, at least the ones affiliated with VCU that are primary care focused, they seem to be operating pretty good right now. So it's a good time they have a whole procedure though. When you call them, you have to call ahead and schedule your appointments and go into waiting areas, and they are operating under social distancing, and it's all quite interesting and new. But don't not access the healthcare system because you're afraid of COVID-19, especially if you need it.
May have been hesitant because with everything that's going on. So thank you for reminding them and encouraging.
May I say something, please?
Yes.
And this may strike a chord with Dr. Hines because I had the good fortune of being an intern when they were developing the Matthew Walker Health Center in Nashville. And one of the prime objectives of Dr. Walker at that time was to provide continuity of care with respect and dignity in the community. And that is still missing to an extent. And I believe that we've got to really get physicians who have commitment to the community and respect for the community, who are involved in the community's life in terms of speaking up if we're going to do things that's going to affect the well-being of individuals who are underserved and maybe improperly served today. And I'm not going to restrict that to individuals of African descent, but it goes across lines.
Sure.
But we're the most visible in this crowd.
Yes. Actually, Dr. Hunter, my next question is for you. COVID-19 is novel, meaning it's new and not a lot of information is known about it. Can you tell us about the study of new diseases which we can anticipate a vaccine?
Well, I think so. But my concern with the coming of the vaccine is that we do it safely, because vaccines have risk associated with them.
Sure.
And we must not get so caught up in developing it very, very fast that we put something out that's going to be harmful to the individuals. And if you go back through the medical history of the vaccines, we know that there have been some problems periodically and suspect continuously, not just the influenza virus, but others. And so I think we have to be very cautious as we go forward, but do it with the best intentions as we can. And also, as we go through this, go back and study outbreaks of various diseases, particularly respiratory diseases, over the past 100 years. See how they were handled. See what we have today that we can use to improve on what was done in the past. And also, as we go through treating the patients, make very sure that we document very well what's happening with the patient and what physiological, pharmacological interventions we attempted and what were their outcomes. So that when things settle a little bit, we can look through a good collection of data and say, well, you did so-and-so and this worked. And so maybe we ought to put this over here and we did this and it didn't work. So maybe we take this out of our armamentarium and our thoughts. And so that's what I think we need to begin to do. Keep good records, close observations, and be willing to talk to each other about what's working. And there's one other thing I think we need to do as we go through this. I think we've got to do a lot of testing, but we've got to go back and pay attention to what the various tests that we are using will provide us. What is its sensitivity? What is its specificity? And did we interpret it right? And not be afraid of saying, I don't know, or I did it not in the best way, but here's where I'll do it going forward.
Thank you definitely for that. I think those kind of echo the concerns that people have, at least I've been seeing via social media and my circles that people have been having about the vaccine, just making sure that we're very cautious, especially within our own community. The next question that I have, any one of you can answer. How do we combat the present health disparities after the spotlight COVID-19 has brought to them fades?
Well, I'm always plugging for us to fight the information war that is happening as well. You know, we have to stay informed, and by we, I mean, I know that the African American community is not a monolith. They are not just one thing. However, we do have a lot of cultural patterns and a lot of patterns that are based based on our history and our shared experiences. So I would say that staying on top of the information that impacts us is very important. And it's not always easy to get the correct information. For example, at the beginning of the COVID-19 crisis, we did think for I don't know if it was a week or a couple of days, but there was a thought that African Americans may even be immune. Because we weren't seeing the impacts very early. But now we know it takes about 10 days for this disease to show its worst attributes. So, we are learning more as we go. But, that thought pattern that we might have about just believing gossip or things that we hear on the street about this disease is not going to cut it. We absolutely have to get to a place where we're looking for the most reliable information possible, whether it's COVID-19 or not, because COVID-19 is with us. It is not going anywhere anytime soon. So if you already had the health disparities and the comorbidities going on before, then it's just all the more reason to keep an eye on your health and stay on top of the problems that you have so that they do not get worse, whether you contract the virus or not.
Well, first of all, one thing I'd like to say, if I may, is let us not be discouraged by bad news. Let us look among ourselves and see what we have, organize that, appreciate it, and begin to share it. And that's not original with me. That's from Aretha Franklin's father. And the other thing is, for physicians of African descent, I think we need to work very hard at revitalizing our local medical societies, our state medical societies, and our national medical association, because that is what brought us to the golden years of the mid-70s. And we got away from it because we didn't feel it was meeting our needs for some strange reason. And now we are in desperate need of those organizations to get out information, to have an influence in policy, because until we influence policy, we are not doing anything. The late Horace Frazier used to say, you don't affect the well-being of folks who are not at the table unless you're at the table and ask the question, where are they and are their needs being met?
Thank you very much for that. I definitely agree. I think we do need to not let all the negative news get us down, especially after this fades, and not let it just be a passing time where we're worried about these health disparities. Let it be something that we're always this passionate about. The next question that I have is open up to all of you again. We hear stories of people going to doctors and emergency rooms and then being turned away or diagnosed with pneumonia and sent home. How can we better self-advocate when we feel we are not being heard?
Well, one of the things is to make sure that we are advocating for ourselves in an effective way. Making sure that you have alternative resources and that you're going to the right place. So for example, someone showing up to the emergency room saying, I'd like to be tested for COVID. Chances are, because the criteria as they are today, and this changes, every day, the criteria as they are for today are not to do testing for as a screening, only if you meet a certain criteria. Of course, that criteria changes from location to location, depending upon what types of symptoms that particular community may be experiencing. There is no standardized set of guidelines that say this is who you test and this is who you do not test. So, making sure that you're going to the right place to get the help that you need. Making sure that you are advocating effectively. So I always tell people when they go to the emergency room, keep it to the bullet points. Because the emergency rooms are very busy. The time where you get face-to-face is limited, and even more so now that we're doing the isolations within the emergency rooms. So if you are coming in complaining about respiratory issues, if that is your number one issue, don't start off talking about what's going on with your big toe. you want to help your medical team to focus in on what exactly is wrong with you. So if you are, for example, having shortness of breath, you want to stay on the shortness of breath path to make it clear that this is what I am experiencing. So that way you can be heard and your concerns can be acted upon appropriately.
Thank you for that. Dr. Hunter, I saw you looking like you were about to speak. Do you have something you'd like to add?
One of the things that we have to work hard at is continuity of care, and that is follow-up from emergency room visits. I don't think we're getting enough of that, and sometimes I think our physicians who are in first-line care, whether they're family practitioners, pediatricians, or internists, are getting the kind of follow-up that they should get, and I don't think that all of the times that they may be available. I'm not sure, because I think the emergency rooms are oftentimes utilized because of availability of those services versus the availability of a physician's office. And I haven't done any private type care for a while now, but that is a suspect that I have sometime. And I just think that the best care is that it is continuous by people who know you.
Yes, I definitely can agree with that because I think your primary care physician will have a better history of different things if you brought up in the past, as opposed to somebody who is in an emergency room and seeing hundreds of people a day. To kind of stay on the ER topic, when should we go to the ER for non-COVID related issues?
I will say that there are some groups that are particularly vulnerable to having poor outcomes during this pandemic. And I will say that that's primarily, I'm understanding that pregnant women are needing to be told to continue your prenatal care, that just because physicians are not seeing patients in the typical way, they should not stop with their prenatal care, because 1 in 8 pregnant women is getting COVID. So it is necessary to go and keep an eye on that and keep monitoring fetuses. Although there are more home births happening now than have happened in a long time. So as long as you're in good communication with your physician, those decisions are being made. People with chronic issues, as we keep mentioning, with hypertension, type 2 diabetes, if you're experiencing changes or differences, you definitely should be seeking care. Now, again, I'll go back to that point about telemedicine. A lot of doctors' offices are asking us to call before we come. So, or if they're taking walk-ins, there's a lot of conditions around having to clear the office space and make sure that there are not more than one persons in the waiting room. So there's a lot to actually going through with the doctor's visit. However, good outcomes are being reported. So don't not access the healthcare system because you're worried about getting COVID-19. Now, if you do find that you need to go to the emergency room, shortness of breath, now we don't know if it's COVID or not, and if you're ruling out anything related to breathing, respiratory issues, as Dr. Hines mentioned, you need to go in and you need to be clear about what it is you're going to be discussing for the day, but call ahead, because calling ahead is going to be key to keeping things smooth. So if you really are in a situation where you would call 911 or call your physician in any other scenario, you should still do that in this scenario, even if it means making a phone call and being set up on a telehealth appointment. And a lot of people, again, are being surprised at their ability to keep a good healthcare relationship going with their primary care physicians while experiencing this stay-at-home order. So we can do it. We can do it. And it is important to communicate. It is important to communicate.
Would you like to say something, Dr. Hunt?
With that, again, we've just got to have continuity of care and commitment, and also understand that the health of one affects the health of us all. And so when we can come to grips that my health is as important as your health to your well-being, then I think we'll be a long ways down the road.
I'll just jump in. In the emergency room, we have been seeing a decline in the number of cases of patients that are presenting with those cardinal symptoms, chest pain, shortness of breath, those kinds of things. And it is concerning because it makes me afraid that people are experiencing heart attacks and strokes at home instead of accessing the emergency room as they normally would out of fear for catching COVID. So, as I've said in some videos before, heart attacks are still happening, strokes are still happening, pneumonia is still happening. We are still in flu season, but kind of in the tail end of that based upon the calendar. And so if you are experiencing any symptom that is out of the ordinary for you, or any worsening of a symptom that you already have, you most certainly should access emergency care. In terms of calling the emergency room, I'm just going to tell you, we are not going to give you that kind of advice over the phone as to whether you should stay home or whether you should come in. Our answer is always going to be, if you feel you're having an emergency, you should come in and be evaluated. And that, that has to be because, we can't have people having, or we shouldn't have people having major health experiences in the house and outside of the scope of emergency care where we can do interventions and improve outcomes. So please come to the emergency room if you think you need to.
Thank you so much for reiterating that, because I do think some people probably are wary of going to the ER when they really probably should. I have another question. And since we haven't really had a lot of participant questions, I think we have enough time for each of you to answer this if you would like. What tips or resources can you offer uninsured or underinsured people during this time when it concerns visiting doctors and receiving sick notes?
So as Dr. Johnson so wonderfully stated about accessing telehealth, there are so many telehealth platforms that are available now that you can access without having insurance. Those platforms won't be free, but it behooves us to do a little bit of research in terms of affordability, because there will be some that may be more affordable than others for the episodic care that we would need. So for example, if you have high blood pressure and you just need a medication refill, telehealth is a great point of access for that. We just have to do our due diligence as a community in finding out what our resources are and then accessing those resources.
I actually did just get a question from a community member, so I want to go ahead and ask that to make sure that they can get an answer to their question. What is the best resource for keeping up with the vaccine conspiracy theory surrounding Bill Gates and his funding of vaccines and then testing them on people in Kansas City and Philadelphia?
Honestly, I would say that when it comes to conspiracy, science, we who learn the science of disease and study the pathophysiology and all the pharmacokinetics and things about the disease, we don't need a conspiracy to kind of give us a moment of pause about when it comes to vaccines. They're highly, they're a hot topic, and they're definitely, while regulated, not experimented with as much as our other medications. So it is natural for people to be leery or worried about new vaccines particularly. The reality though is that this is a novel virus, and that meaning that we don't have a defense for it that we've built up over time. So that's why the information has to come in because you have to make an informed decision as a healthcare consumer that's based upon the knowledge that you're gaining from trusted resources. So if you trust Dr. Moore's word about what she's saying, find out, or if you're her patient, then you're going to probably trust that if she says that you need a required therapy as her patient, your trust for her is going to allow you to make a decision that's in keeping with what you think is best for yourself and what your healthcare provider thinks is best for you. So that's a personal decision for everyone, whether you do it or not. Look, I like to put on my tinfoil hat as much as the next guy every once in a while, but the scientist in me says that we have to really consider the fact that we're dealing in unprecedented territory here. So we definitely want to keep our eyes out. I'm a proponent of building up our immune systems and working really hard, because we're not going to have that vaccine for another 18 months. So we got to survive that. A lot of us have to get to the place where we can make a choice about a vaccine. Some of us won't make it if we are not really doing things to build up our healthcare, our immune system, and improving our comorbidity. So, that's a touchy topic, so I don't want to say the wrong thing, but I will say that get the information up. Don't just study Bill Gates. Also look at what the latest protocols are that are coming out of your, or talk to your healthcare provider. If you don't want to get into the weeds on medicine and all these things, just talk with your healthcare provider. Give them an opportunity to give you some feedback about what they think you should be considering.
Yeah.
Also, I'd like to add 2 resources there. I check periodically at cdc.gov, which gives a broader overview of what's happening with COVID in our country, in terms of protocols and in terms of statistics, but then also your public health department. That may be an even better resource, because that is giving you local information that is pertaining to what's happening in your particular community. Those websites usually have great information, about access to testing if you should need it, number of cases, comorbidities, and that kind of thing. So those are awesome resources that are, as far as I have seen, unbiased and untainted by the myths that can come out of just community chatter about whatever things. And there is most certainly a good reason for that, because historically people of color, and particularly African Americans, have not necessarily been treated fairly by the health system. Everyone, well, most people, I won't say everyone, most people probably have heard about the Tuskegee experiment. And that has had such a long, lingering effect of the trust of the healthcare system within our community. And so that kind of gives precedence to how these myths kind of catch on and spread like wildfire, because there is that mistrust. So as Dr. Johnson was saying, finding a source that you trust, and finding sources that are reliable and not under certain influences, be it political or whatever, that's a great place to start. And then, of course, you can get to your primary providers as well for sources of information.
Thank you. Before we close out, Dr. Hunter, is there anything you'd like to say or chime in on the discussion?
Yes, it's important that we stay as current as we can, so that we can know and maintain the trust of our patients, so that they can have a place that they can come. We can say, I don't know, but at least be as honest as we can, as often as we can, by trying. And the other thing is, as we talk about what can we do in the COVID-19, for those individuals that have recovered, I would suggest that you call your local American Red Cross and ask about being a convalescent plasma donor, so that we have a tool with which to combat those serious complications of COVID-19.
Thank you so much. I'll wait to see if my president is going to hop on. And then pulling up the flyer that we will be doing for Sunday, May 10th, which will be community resources.
Thank you so much, Courtney.
Thank
I
you.
really appreciate you moderating this today. Such great information. And I would like to thank Dr. Samuel B. Hunter, Dr. Candace Johnson, and Dr. Carissa Hansmore for all of your expert information in regards to health disparities and COVID-19. We here at Asala Richmond wanted to invite everyone all over the United States, so we were able to get more people. We have people on this line from Philadelphia, New York, California, Texas. So we're excited and happy that all of you all have tuned in. As you can see from the information, we have next week, we have African Americans, COVID-19 and community resources. And that should be a great topic for us to just dive into how can we in our community help others. And it might not be just for the Richmond, Virginia community. You might want to help someone, you might be from Idaho, or you might be from Texas. So we're going to have a discussion next week, and we're going to talk about food and unemployment and things of that nature, so that we can get more information and be able to use it for ourselves. I appreciate everyone being on this call today, on this webinar. And what I am going to do is I'm going to leave this webinar up for if someone has a question or if someone has a comment. And if after that, then you can go on and we will email you about all of the wonderful things we're doing here at Asala Richmond. Asala Richmond was founded last year in 2019, and we have been on and rolling ever since. So thank you so much for all of your support, and we look forward to working with you in the future. Have a great day.
Amazing grace, how sweet the sound that saved a wretch like me. I'm found. I was blind, but